Basically, the most common cause of PMS as well as PMDD is these hormonal fluctuations. And really, what I want to stress throughout this entire presentation is that it's not the amount of hormones, it's not the amount of estrogen, progesterone, testosterone. We all have, even females produce testosterone, but it's actually the sensitivity to the fluctuation in hormones throughout the cycle. And that cyclical cycle that happens, basically if you have a normal 30-day cycle, and then the first 2 weeks your estrogen's increasing, and then your estrogen surges right before you're about to ovulate, and then comes in that lovely progesterone, and that leads up to what's called the luteal phase, and then the PMS phase, the couple days, week before menstruation. And all of that, some women are more sensitive to these changes. And even more interesting, and what they're finding out with some, really big studies, is that although there's not enough studies out there on PMDD and ADHD, but there is a correlation between the two. And so really what I want to also mention here with the potential causes of PMS as well as PMDD is that what we do also know is that women are not just sensitive to the hormonal fluctuation, but also to the neurotransmitter disruptions in the brain. So when women actually have different levels of something called serotonin, dopamine, acetylcholine. Just think of those as the chemicals in the brain, and then they interact with estrogen, progesterone. But what we know is that not only are those folks sensitive to estrogen and progesterone, but also low levels of serotonin have been shown to occur during what's called the luteal phase, which is 2 weeks before your menstruation. So no wonder why you feel kind of irritable, down. Low levels of serotonin, make you feel that way. And so this is all chemical. And so just a little side note, this is real. I mean, the PMDD is real, and that's something so important to make clear that, all these, I know it's been a later diagnosis. It took a while to get into our DSM, diagnostic statistical manual, but it's a real thing and it's not your fault. So let me speed up here because I know that, my time blindness is a thing, just like other ADHDers. So I want to keep on track. So exploring treatment, I'm going to, basically, if it's mild, you can stick to lifestyle changes, you can stick to over-the-counter pain relievers, you can stick to hormonal contraceptives. That just means, birth control pills, as well as patches or the NuvaRing. And then you also can talk about some integrative type of treatments if it's really mild and you just want to look into something like acupuncture, or there is this herb called chasteberry, which has some sort of evidence, a little bit more than Primos oil. I wouldn't actually say that there's much evidence to that, even though you may hear about it. All right. So one thing to know, we've already discussed, or I've discussed, PMS and then PMDD, which is premenstrual dysphoric disorder, which is, basically that more severe form of PMS. But we also want to mention, which is so important, is PMS exacerbation. And so think of this as any medical or psychiatric condition that you have actually can worsen during those 2 weeks, the luteal phase of your cycle. And so the conditions that are most likely to be affected are ones that are kind of affected by hormonal fluctuations, such as migraines, asthma, diabetes, also epilepsy. And then also the psychiatric ones that are depression, bipolar, and anxiety. And so what we really want to make sure of is, are you getting diagnosed correctly? Are you, as your clinician, really getting the full story? Since the treatment varies, really, I'm not, I'm really into labels and diagnoses only if it really changes the treatment. And so if someone has, symptoms that are lasting the whole month, and, we're only thinking about PMS or PMDD, then, we really need to reevaluate, is this possibly just a exacerbation of their underlying, unipolar or bipolar depression. And the reason that I bring that up is usually the treatment's different. What we do is we just increase their mood stabilizer or their antidepressant maybe for that week or 2 weeks before. So just something to keep in mind. You can have both.